This is where we are now in the United States, doing about 160,000 coronary bypass operations annually, and you can see that it's quite stable over the last 20 years. This is the FREEDOM trial. Dr. Fuster gave me this slide from 2012, diabetic patients randomized to PCI versus CABG, and you can see a striking benefit for CABG over PCI for death, stroke, and MI, the hard endpoints, beginning at 3 years and expanding through 5 years of follow-up. The SYNTAX trial was perhaps the most representative trial yet conducted because the patients enrolled were most representative of general practice. And in that trial, we saw for MACE, for death, stroke, MI, even for all-cause mortality, and myocardial infarction, and repeat revascularization, but not a difference in stroke. We saw for those other endpoints at 5 years a striking benefit for CABG over PCI. Dr. Sorois recently presented these data on the 10-year follow-up and was kind enough to give me these slides, reminding us of the 5-year MACE results striking me in favor of CABG, all-cause mortality at 5 years approaching significance for CABG, 10-year all-cause mortality approaching significance for CABG, and in 10-year mortality for 3-vessel disease significantly in favor for CABG, although not in left main patients. This is the summary slide from that presentation looking at SYNTAX scores, and you can see favoring CABG above the horizontal line, favoring PCI below, for higher SYNTAX scores in all patients, intermediate SYNTAX scores in 3-vessel disease, but not in left main, favoring CABG. So where have we been with CABG? I'm going to talk about 4 eras: an experimental era, the vein graft era, the mixed ITA in vein, and now the total arterial era. The first experimental era began with Alexis Carrel, who first described the concept of operating on coronary circulation and did so in dogs, and for this and other things he won the Nobel Prize in 1912. The Canadian Arthur Weinberg did the first ITA grafting in human beings as early as 1950, just after the Second World War, but he implanted the ITA directly into the myocardium of the LV. He did not anastomose it to a coronary artery. That task was first accomplished by Dr. Kolosov from Russia, who reported the first successful clinical CABG in 1959. The Weinberg legacy was important, however, in order to demonstrate that an internal mammary graft implanted into the anterior myocardium could develop collaterals and remain patent, documented by later angiography. As mentioned, René Favallara, although perhaps he did not perform the first vein graft bypass, he did at least publish the first systematic series of vein grafts, initially with patch and then with bypass grafting from the aorta. Here in this aorta coronary bypass graft, describing 180 patients up until October 1967. But as early as 1970, we already see this histopathologic analysis of the failure of vein grafts and the appearance of the term intimal hyperplasia to describe the failure of vein grafts. This is 1970. I was 10 years old. In 1968, when I was 8 years old, George Green performed the first ITA anastomosis to the LAD in the United States of America in New York City. In fact, Dr. Green in 1970 began to have the job that I have now. He ran the coronary bypass program at St. Luke's Hospital, now called Mount Sinai St. Luke's Hospital. And he ushered in the era of mixed ITA and vein grafting. And it wasn't long before we began to understand that the ITA would last longer than the vein, and we saw several interesting papers identifying why at 2, 6, or even 12 years, IMAs remained unchanged histologically, and histopathologic study of vein grafts demonstrated intimal hyperplasia and subsequent atherosclerosis. Why is that the case? It is probably that ITAs are nitric oxide pumps and pump the nitric oxide directly into the coronary circulation. So now we are in what I hope will be known in the future as the 4th era of CABG for total arterial vascularization, which can be accomplished basically 2 common ways: by using bilateral ITA grafts, shown here, or by using radial artery grafts to augment a single ITA. Let's talk about the bilateral ITA first. You've seen some of these slides before. This is Bruce Lytle's paper from 1999. 2 internal thoracic arteries are better than 1. And you can see for survival or intervention-free survival over 10 to 12 years follow-up, beta outperforms zeta. And this was emphasized in a more recent paper, editorial by Dr. Tim Gardner, the central message of which was that 2 ITA grafts are better than 1 and should be the standard option for most patients. Takagi did an interesting meta-analysis in 2014 of about 70,000 patients documenting a survival benefit with a hazard ratio of about 0.8. And this applied whether the ITAs were harvested in pedicle fashion or in skeletonized fashion. Both favored the bilateral ITA grafting operation. I became very interested in that about a decade ago and looked at about 15,000 patients at Emory University, stratifying them according to double mammary grafting and presence or absence of diabetes, because I wondered whether in the modern era bilateral ITA grafting would have the same benefit that it had way back in the 70s when patients were typically not diabetic. These are the survival curves of propensity matched patients having beta without diabetes, beta with diabetes, zeta without diabetes, and zeta with diabetes. And you can see that the beta non-diabetic patients had the best survival, but the beta diabetic patients outlived the zeta non-diabetic patients. In effect, a second arterial graft compensated for the fact that these patients had diabetes, and they outlived those single mammary graft patients who had diabetes. Dr. Taggart's landmark study called the ART trial has been discussed already. These are kindly provided slides from him from the European Society of Cardiology of this year. You know this is a large RCT of bilateral ITA versus vein grafts conducted at 28 cardiac surgical centers in 7 countries, enrolling over 3,100 patients. You've heard some of these issues and the reasons why the intention to treat analysis doesn't really describe or explain the outcomes of this trial, but rather we need to also focus on the as-treated analysis, because 36% of patients received a different strategy than were initially intended. In particular, 14% of the bilateral patients had a single ITA, and 22% of patients assigned to the single ITA group in fact received a second arterial graft in the form of a radial conduit. So if we look by intention to treat, those patients assigned to single ITA and bilateral ITA had almost identical survival over 10 years. But in terms of as-treated analysis, patients having a single arterial graft had a much worse survival compared to patients who received at least 2 arterial grafts. Similarly, death, stroke, and MI at 10 years by intention to treat was not different, odds ratio of 0.9, and a confidence interval that passed the midline. But in an as-treated analysis, patients receiving multiple arterial grafts had better avoidance of death, stroke, and MI at 10 years with a highly significant comparison. Again, a hazard ratio of about 0.8. Very similar to what Dr. Lytle had found a decade earlier, 2 decades earlier. This is a very interesting analysis by Umberto Benedetto of that ART trial. I think you've seen this slide before, describing the great heterogeneity among surgeons and centers with respect to their ability to reliably harvest 2 internal mammary grafts and use them in a bypass operation. 14% overall of patients assigned to beta actually received zeta. And that varied among centers from a 0 conversion rate to a 50% conversion rate, and among individual surgeons from 0 to 100%. So it turns out that we, as a profession, are not as good at harvesting double mammary grafts as we think we are. And it makes a difference. This is just Dr. Taggart's results in only 400 patients, 416 to be exact, randomized to receive single or bilateral ITA with only 1% crossover. Even among only 400 patients, you see a mortality benefit of 10 years, specifically a benefit that isn't evident until about 5 years out and begins to diverge thereafter. So a biologically plausible set of curves here. So there's another way to get to total arterial vascularization. That, of course, is using the the other easy arteriograph, which is the radiograph. Interestingly, that graph was initially used by Dr. Carpentier many years ago. In 1973, they published this data. And it's interesting, if you look at the discussion section, it's clear that that was presented in a meeting where both Dr. Carpentier and Dr. Green were present, because they discussed the differences between the ITA and the radial artery in the comment section of that paper. And frankly, the initial results with radial artery were somewhat disappointing, but the revival of that graph came with this paper from Akar in 1992, demonstrating long-term patency of arterial conduits in selected patients. So we began to understand how to use them and when to use them. And more recently, randomized trials, this is the RAPS trial, demonstrating that freedom from functional and complete graft occlusion was superior with a radial artery versus a saphenous vein graft. At our own institution at Mount Sinai, we did a retrospective analysis looking at survival of patients after single mammary and radial versus single mammary and saphenous vein, and then projecting that survival benefit, which was striking in our own population by this propensity match comparison. We projected that to the entire national volume of coronary bypass surgery and concluded that we would save 64,000 patient years of life over the course of 10 years if every surgeon in America accomplished an 80% rate of using at least 2 artery grafts. That was amplified by this report by Mario Godino and others, the Radial Artery Alliance study presented at AATS and published in the New England Journal, demonstrating that a single mammary plus radial artery had a reduced risk of death, stroke, or death, MI, or revascularization at 5 years in this meta-analysis, and a reduced rate of graft failure, so the biological plausibility of the outcomes is consistent, as well as a reduced risk of repeat revascularization. This was published very recently in the New England Journal. Dr. Buxton from Australia has led a group of Australian surgeons who have had for at least 3 decades a strong interest in multiple arteriography and more particularly in total arterial revascularization. And here they compare their outcomes at 15 years of follow-up in this propensity matched series of several hundred patients, comparing total arterial revascularization versus single mammary and vein grafts, and demonstrating a striking survival benefit. This is incorporated into the present STS, AATS guidelines, advocating a second IMA graft to the left circumflex and complete revascularization in younger patients. The European guidelines from 2014, which as you saw have been very recently updated, are a little more aggressive and push us towards more total arterial revascularization. But within the United States of America, we've just got to 100% use of a single mammary. And bilateral mammary use has just now reached 5%, meaning 95% of cases performed in the United States of America in 2017, isolated primary coronary bypass, had a single internal mammary graft. And that's not because they all had double radial grafts. In fact, radial artery use has declined over the last decade, and now is about the same as double mammary use, 5%. So what can we do to improve both on-pump and off-pump coronary bypass? I think improvement in our operation is our future. So my topic was the future of coronary surgery, and I think it has to be a future of continuous improvement. The Achilles heel of coronary bypass is stroke. And I remember very clearly the 1-year data from Syntax, which showed these curves, a 2.2% risk at 1 year of stroke in the CABG population and a 0.6% risk of stroke at 1 year in the PCI population. At 1 year, there was no difference in death, MI, or repeat revascularization, but there was a difference in stroke, and that was in favor of PCI. So stroke was the focus of the discussion at 1 year, and in fact, it should be a focus of discussion. Here's the FREEDOM trial at 5 years. The risk of stroke is still at 5 years in that trial among diabetics, higher in CABG patients than among PCI patients. Part of this finding in both these trials may be asymmetric use of optimal medical therapy between CABG and PCI. In almost every trial, the CABG patients don't get as good medical management as the PCI patients. And frankly, that fault rests with us. How do we avoid stroke in the operating room? We make an image of the ACE in the aorta. You've seen some beautiful images from Dr. Kim and others, Dr. Arai, of the ACE in the aorta. This is a spectacular image of a stalactite in the ACE in the aorta, a dramatic lesion that isn't palpable, but you certainly wouldn't want to put a clamp on that. That was in my own operating room about 15 years ago. This is much more common, a medial thickening without dramatic calcification, but this is several millimeters thick. It's 3.2 millimeters thick here, and this sort of tooth-based debris in the media is not palpable, but can be extruded by a clamp. We did a careful study looking at the effects of aortic clamping on neurologic outcomes after coronary bypass, and the bottom line is, in on-pump cases, a double clamp doubles the risk of stroke compared to a single clamp. And in off-pump cases, a partial clamp versus no clamp almost doubles the risk of stroke as well. We do want to assess the quality of our grafts, whether it be on pump or off pump, and we do this in every single case without exception. You've seen these images and the technology displayed. And of course, this comes up on a slide, on a tablet in the console in the operating room, and informs our quality control in the operating room. Nonetheless, whether it's on pump or off pump, dual antiplatelet therapy improves graft patency, and it probably improves saphenous vein graft patency more than it does arterial graft patency, and it probably improves off pump vein graft patency in particular. And that is without a risk of increased bleeding. It does in fact benefit early mortality in these CABG patients. So I think this is an important factor. David Taggart showed this slide earlier. It's I think, the most striking single graphic that I've ever produced from a research study. And this is way back in 2009. We looked at off-pump and on-pump patients, 15,000 patients at Emory, and found that there was no stroke, no mortality benefit to off-pump bypass compared to on-pump bypass for low-risk patients. But as you looked at higher and higher risk patients, the divergence between the off-pump mortality curve and the on-pump mortality curve became greater. In other words, the mortality benefit of OPCAV is non-existent in very low-risk patients and is increasingly present in higher risk patients. This has multiple implications, perhaps the most obvious of which is if you were to do a randomized trial of off-pump versus on-pump and only enrolled low-risk patients, you would never find a mortality benefit because there isn't one. The survival benefit of OPCAV appears with a predicted risk of greater than 2.5% and increases as mortality risk increases. This is a paper in which we looked at the STS database in 42,000 patients, analyzed according to the 32 risk factors that comprise the STS predicted risk of mortality. And we wondered whether women, being a higher risk group, would benefit more from OPCAV than men. They do somewhat, but all patients benefited from off-pump bypass. With these odds ratios, all